Good afternoon and welcome to the Emerging from COVID-19 panel on using data to transform whole person services and supports session.
Thanks so much and welcome to convention, everyone. We're very pleased to be the first breakout session. My name is Doug Golub. I am president and co-founder of MediSked, and my panelists.
Good afternoon. I'm John Nash. I'm the executive director with the ARC of North Carolina.
Good afternoon. I'm Kevin Zingler. I'm the president and CEO at MARC Inc. of Manchester in Manchester, Connecticut.
And what topic could be more 2021 than an analysis of the data behind COVID-19? The difference between this year and a year ago at convention is that while we were all hit pretty unprepared and unexpectedly with COVID this time last year, going into last year, for this year, we have significant data to take a look at that we can learn some lessons about the road ahead, help improve individual well-being and performance and health, welfare, and safety. And so we take a look today at some data from across the country and some incredible stories and lessons from providers for COVID-19 and the IDD population, specifically the ARC of North Carolina and MARC Inc. in Manchester, Connecticut, as we go into our panel discussion. And so with that, one of the things I think we've all recognized is there's plenty of COVID data out there, but not necessarily for people with IDD. We look to improve that today. We all do know that the IDD population is at a greater risk of adverse outcomes from COVID-19. We also know that unvaccinated people are 17 times more likely to be hospitalized due to COVID-19. And with IDD, it is the strongest independent risk factor. People with IDD are 2.5 times more likely for presenting with the COVID-19 diagnosis and certainly mortality rates. And so when you put those two items together, the people that we support with IDD and vaccinations, it helps us take a look at some of the biggest risk factors out there. For today's presentation, we took a look at about 1,000 people with IDD. And of those that we looked at, about 12 people, well, exactly 12 people did not survive their COVID-19 diagnosis. Of those, 11 out of the 12, or 92%, were either over the age of 65 or had one or more of the risk factors in addition to their IDD diagnosis, which is pretty powerful for this population. And unfortunately, that number was 12 people. Fortunately, it was not larger than 12 people. And that we take a look today at some of the factors and outcomes. And specifically, as the focus shifts now to booster shots, some of the lessons that we've learned over the last year and a half, we never reached everybody with vaccinations. And for many of the folks that were reached, it's time to do it again for booster shots. And so those lessons learned and those stories help us understand where we're going. The data that you look at today came from MediSked Connect, which is the data management platform used by many providers, including the ARC of North Carolina and MARC Inc. of Manchester, Connecticut. And so some of the data that you see today, this is where it came from. Of course, it was entered by staff. And the chapters of the ARC advocated significantly to allow for access to vaccines. And so with that, our panelists will mention some of what they did to help people access vaccines starting as early as January 2020. We'll start with John.
Sure. So like many states, North Carolina put people with intellectual and developmental disabilities much lower on the list of priorities over the course of particularly last winter, December and early in January of this year. We were able to move that needle significantly, and certainly into February when we were finally able to make all people with IDD the highest priority. Originally, the mandate was people in congregate settings and care providers were moved up the list after the initial announcements. And then later on, after us making a very strong case, using the data that we had, Johns Hopkins was certainly high on the list. We turned to them for on a regular basis, just to provide the science and the data backup when we were using science as the reason for putting us towards the back, we were able to pull that data up and say, listen, the science is telling us this, and it made a huge difference. Once the initial decision was made, again, just for people in congregate settings, we were able to move people in all settings, regardless of where they're living, at home, independently, from the end of the list to the front of the list, simply because we had the data. And again, some of the data that we're going to be looking at today was instrumental in helping us make those cases with our State Department of Health and Human Services.
And in Connecticut, we were fortunate to our governor, Governor Lamont, and also our DDS Commissioner, Jordan Sheff, recognized the importance of getting the vaccine out sooner rather than later to our population. So I got a phone call actually on Christmas Eve in the afternoon, and it was a very powerful call to say that we have a CVS clinic scheduled for you guys. It'll be on January 6th. Please line up all your folks to get the first shot. And we were ecstatic. If you recall, at that time, the first couple of folks within the hospital settings had just gotten their shots all over the news. It was the waiting holiday present for everyone, if you will. So we were very fortunate in Connecticut that we didn't have to go down those advocacy routes, that they understood our population. They really wanted to make sure that our population was protected. And we were very fortunate to get that first dose on January 6th in Connecticut.
We're going to start taking a look at some of the data in North Carolina, and we'll start with John.
All right, good. Go ahead and give us the next slide. So the ARC of North Carolina has a kind of unique circumstance in that we are contracted with the state of North Carolina as a corporate guardian. We don't determine where people live when we are assigned these cases. This comes from the courts. When somebody is adjudicated to their term incompetent, we are then assigned, if no one else, no family member is able to provide that support for that individual. And so we are one of several corporate guardians in North Carolina. And in that role, we provide that corporate guardian support for about 800 people, which gives us a really good homogeneous population. We know where they are. We know what's going on with them. We know if they've been vaccinated or not vaccinated. We have a very clear set of data that we work with, and it's all part of our work that we do with using MediSked. So in that role, the first graph that you see here is just the where people live. I mean, where are they, and helping us kind of define what is the data telling us. About 47% live in some kind of a certified setting. 42 live in a non-certified setting, and 11% live in an institution. Again, this is the population that we receive when we are given this assignment. Our work then is to figure out how do we support this individual, and really a lot of work has gone into how do we restore those rights to those individuals. And again, part of what we're talking about here with vaccinations is part of that. How does somebody make their own decision appropriately? Go ahead and let's see the next piece of this. So within that population, some in settings, in certified settings, some in non-certified settings, the bulk of our population are around the average age of 50. This is an adult adjudication, so we deal primarily with adults and not with children in this case. But as you see, the age distribution starts to drop off as people get older, as you would expect. Go ahead and pull up the next picture. The next piece of this then is the guardianship program and the comorbidities that we provide. So of this group, 60% have simple IDD, they're just IDD specified. The rest have 23% have one additional comorbidity, 12% have two, 3% or three, 5% have three, and then 1% have four. So there's a lot of information that shows what's happening if there is nothing else going on other than the additional diagnosis, and what's happening when something else is going on there, and the data that backs that up. Go ahead and let's get the next slide up. Other information that obviously when vaccinations were made available to us in January, we saw the peak in January and February after we did an awful lot of work to get those individuals available to receive the vaccination. We moved them up the list, and then things tended to drop off significantly all the way through the late spring and into the early summer. Going into August, we started to see the rebound, and again, we see the population, the numbers start to pop up again in August for vaccinations when it becomes more and more important that we do that. And I think people, that reflects somewhat of a general population. I mean, everybody's following a similar track there, I think. Go ahead and let's have the next slide. This slide then represents where our people are across the North Carolina that we are provided guardian supports for. And it's a little misleading because the darker squares, the darker counties are where we were fully vaccinated, the lighter squares where we were partially or not vaccinated at all. And while it looks like, gee, is there a story to tell? And answer is yes. And even when data is questionable, it tells the story. And in this case, where we have the large metropolitan counties, Wake County, where Raleigh is the capital, Mecklenburg, which is where Charlotte is, populations are much larger and closer together, and we have a little different dynamic working in that environment versus some of the rural counties, where in some cases the rural population isn't as vaccinated, but our population is, and we're only dealing in some places maybe 1 or 2 or 3 people in the entire county that we would be supporting as a guardian. So it's kind of a mixed bag, but it tells us something, and specifically things that we're looking at in terms of culture, population, urban, rural, and metro, north and south, and east and west, all are different dynamics, particularly in a state the size of North Carolina. And so all these things become issues for us to consider, particularly if we're doing a person-centered approach, which is always the ARC of North Carolina's intent. How do we appropriately teach somebody about a vaccine when they're in a community or an environment or a social group where the vaccine may not be well appreciated or desired? And so it's, how do we give people enough information that they can make their own decisions and then stand back and let them make those decisions? And that is truly a person-centered approach. It's complicated when you're spread out as far as we are here. Go ahead and let's see the next slide. So the vaccination rates by age, it increases as you get older towards the middle of the group. And then once we hit the peak at 50, 55, 60 years old, then it starts to slide off. And particularly with the older population, the vaccination rates go from 78, 65, 70, 75% down towards the end, where we're almost running at 50% for our older population. I don't have an answer for that other than we're taking a close look at this now. What happens with older people, and do they choose or not choose, and why would they not choose to be vaccinated in the current environment? Next slide. So with this slide, we're taking that initial graph of the population demographic, 0 additional comorbidities versus 2, 3, and 4 comorbidities on top of intellectual and developmental disability. And we know it's interesting because we know that the more comorbidities you have, the greater the impact is, the more impact that both acquiring COVID-19 and being vaccinated will have on the person. And yet the numbers that we see across the board, regardless of whether you're vaccinated, whether you are vaccinated or unvaccinated, for instance, diabetes, if you look at these lines on the bottom left-hand corner, 21% have diabetes, 22% vaccinated have diabetes. So the numbers don't shift that much depending upon the comorbidity. So the comorbid issues are not necessarily the driving factor. The question is, do you have a disability, and have we educated you appropriately? The next slide.
And this one's also, we have 2 questions. One from John from the ARC of Oregon. How are we advocating or communicating that a vulnerable community that are allowed first in line shots in January and now booster shots may or may not include on the list with those DD concerning COVID-19 booster shots? And that's particularly interesting here because back in January, if you were to look at these numbers, because access was an issue, of the population, the vaccinated population was almost all people with comorbidities or over the age of 65. And what we found is over the course of about 9 months, where access was no longer an issue, as you can see here, 38% versus 41%, it kind of all came out in the wash. Yeah. Where you don't see that people that are at higher risk are more vaccinated, at least with the population that we studied. You certainly did back in January, February, March, because they were the only ones who could get the shots. But now that anyone could, it really did balance out.
Yeah, and we appreciate that, Doug. As time went by, initially there was a big surge, and part of it was because it wasn't just our effort to get this change, wasn't just the ARC of North Carolina working behind the scenes. This was a huge public effort. I mean, when the ARC is a grassroots entity, and we very much are, that's our strength, the grassroots really came out. And so there were news stories, there were public conversations going on. There was before the camera, behind the camera kinds of conversations that were happening. And yeah, up front, we saw the huge spike in vaccinations that dropped off as time went by. And again, as the issue becomes more and more prevalent with the resurgence, you know, once again, we see people going back and saying, "Ooh, I better get vaccinated." And we probably have a little bit better information for our purpose in working with somebody with a disability, be able to communicate that. We've got time, we've got some better experience, and we're able to better teach people what it is we're talking about and what the impacts may be. Interestingly, and I honestly, and Doug, if you got a thought on this, we've talked about this a little bit, the difference, I mean, I have some thoughts why it is that somebody who smokes is less likely to be vaccinated amongst our population. And it may be that, hey, if I'm going to smoke, you know, I'm safe, I'm good, nothing else is going to harm me. And that is anecdotal and simply a supposition on my part. But we do see that if somebody is a smoker that's amongst this population, that the likelihood is a much lower incidence of vaccination. Interestingly, we also know that these are one of those things that would have a negative effect or an adverse effect on if you contracted COVID-19 in the process. So there's some work there that we have to do. Next slide. We do a lot of in-home supports, and so we measure and watch this. Interestingly, over the course of the pandemic, if you look at 2018, 2019, and into 2020, about the time that the pandemic hit in March and April, we see a huge dip in people acquiring or needing or wanting to use in-home supports. And we saw this. We actually laid off an awful lot of people and then brought them back as quickly as we could, mostly because, and there's still that case, families say, hey, unless I love you, we've worked with us, you are part of the family, but if I can't guarantee where you are and what you're doing in the afternoon when you leave here, or in the evening when you go home, or your after hours, then I can't have you in my home with somebody with a compromised immune system. And so those in-home supports we saw drastically drop off. They've come back up somewhat, but again, it's much lower than it has been in the past few years. And we expect that as the pandemic completes its cycle, hopefully gone forever, if not at least ways under some kind of control, that we'll begin to see more and more people taking control of what goes on with their loved ones. And it's been an interesting transition for us. Self-direction, same kind of thing. Self-direction means you take on an awful lot of responsibility to manage your system. It hasn't really dropped so much, mostly I think because a lot of people are at home taking care of their loved ones, where before they were at the workplace doing this. And so self-direction has slowed off. It's peaked, it's always grown over the years, but here again, over the last, you can see the marked turn in where we're headed about the time of March of last year, when the pandemic really started to take effect. And so the same kind of thing is going on. What is the result of the pandemic on people making their own determinations? And it's the same thing that we're seeing in other places. So ultimately, it's a question of how do we help inform, what is the message we need to send, and how do we go about getting that to the individual and to the family so they're able to make the best decisions possible.
Thanks, Sean. And now we're going to travel to Connecticut and take a look at a different story with a lot of similarities, but some differences with Kevin.
Great. Thanks for having me again, Doug, and thank you to the ARC for hosting this. So we're going to look at our residential population because that was, when we were looking at COVID, when it first broke out here, how are we going to cover our group homes? How are we going to cover our residential settings? Our day services had shut down. So we really focused in on how that was happening. And thankfully to MediSked, we had real-time data to assist us in that process. So next slide. So we're going to describe our population. Basically, we have 54% living with our residential services here at MARC, and then Other settings would be 46% of individuals who are at home or live in like a CCH, community companion home provider, other types of situations. So really the 51 individuals in our residents operated by MARC Inc. and the 99 individuals and other residents operated by other providers makes up that 54%. So the age distribution, so we're right around the average of 46 years. So we have folks that are obviously well into their 60s, and we have folks that are newer to our organization in terms of the age distribution. But this is overall for our agency. So I think the national trend is 35 or 36 is the average age in the United States. So we're just above that average at 46. Residential vaccinations, as I mentioned before, we had the very great opportunity to get a clinic here, one of the first clinics for the IDD population in the state of Connecticut through Omnicare/CVS. So you'll see there from December, we had a 0 and then we spiked up to 41 people. So people were really anxious. Families were anxious. Our guardians were anxious to get this vaccine, to get the first shot. They realized that after living for the last 9-10 months in this world of COVID, that we needed to get this vaccine into folks, and we didn't have a lot of pushback in Connecticut to get the vaccine, which I think has led us to be the #1 in the state for vaccine distribution. So I think we're at 77% for our entire population, at least one shot in the state of Connecticut, and 68% for fully vaccinated at this point. You'll see in February, we had a lockdown. Unfortunately, in January, actually, we did have suspected exposure COVID cases. So obviously they couldn't get the vaccine. So we had several individuals who were in a lockdown, and we basically had them get their first shot at our February clinic, which for the most part was their second shot for those 41 individuals. So as you'll see, it sort of mirrors what John had experienced. Basically, there was a real influx in the beginning to get the shot, and then it sort of leveled off over time. And we're starting to see a little bit of an uptick based on the Delta variant. So of folks who are a little hesitant, or guardians decided not to get the shot initially, or wanted to wait and see if the science matched some of the data. So, but we're in a really good a really good position, because 98% of our individuals living in group home settings are fully vaccinated. And as I said, I think this statistic was as of 9/1, but as of 9/25, the latest data from the governor's office was that 69% of the residents are fully vaccinated, and 75% have at least one shot in them. Next slide, please. So our day services, day programs took a hit just like everyone else's. We got the memo just like everyone else in the state to shut down in March. You'll see the drop there. Even though we shut down physically, we were one of the first providers in the state, actually the first provider in the state of Connecticut, to pivot to virtual services. We shut down on Friday. We opened up on Monday with virtual services. And really that became a lifeline for our individuals to engage with each other, to socialize, to sort of go through this COVID world together and experience it. And we have had a wonderful success with our virtual services. We actually have our individuals now hosting their own shows and sessions, which is awesome. I know that MediSked reached out to us early on and wanted to partner with us, and we were working with them in terms of engaging folks, engaging staff, and thinking about things. And you'll see that through this time, day and employment services has started to come back, if you will. So here we are in August of 2021, and we're not back up to where we were, but people are now getting comfortable coming back and doing their full days of services with us in terms of hours. So our employment services, you'll see that the trend sort of mirrors our day and employment, day service option. Our supported employment, where we go out into the community, folks have jobs in the community and work in the community, took a hit as businesses closed down in the state. Jobs were not available for folks. Our folks, rightly so, at that time didn't have access to the vaccine back in 2020. So parents and guardians were hesitant about putting our folks at risk into the community. So we had a dip there. But I wanted to go through some success stories, because we have really found out through this pandemic that there are a world of opportunities that are now becoming available to us. as the unemployment rate, folks are looking for workers at this point. Our guys are now getting in line to get these jobs, which is great. So a couple of them, first off, the one in the middle, the photo there in the middle, you got a gentleman, looks like a Home Depot Lowe's photo. It's actually Lowe's. His name's James, and he got hired during the pandemic. And I'm proud to say that he just celebrated his first anniversary at Lowe's. So he's been there for a full year at this point. He got a job last summer there and does a wonderful job. The guy in the lower right-hand corner is Robert. He works at Big Y. It's a grocery store. He's been working throughout the pandemic. He's been at Big Y for many years. But I wanted to highlight him because, one of the things that we saw is the resiliency of our individuals served and how they continued to go to work and show up to work. And that was meaningful for organizations and stores and businesses that remained open, even on a limited time basis during the pandemic. So Robert was one of those rock stars who was throughout the pandemic, always there. And everyone knows him by name. Everyone asked how he was doing during the pandemic. If he wasn't there, where's Robert? That type of deal. And those community connections are so powerful for folks during the pandemic, especially when we're sort of isolating ourselves through this endeavor. So the folks in the lower left-hand corner, they're working at Hartford Hospital, one of our major hospitals here in the state of Connecticut, doing buildings and grounds work. And they do a phenomenal job at that. So there are opportunities out there. I just tell you to knock on that door when you see the for hiring sign out there on the street or online, because these guys are just really benefiting from this opportunity. Next slide. In-home supports. So just like John had mentioned, we do in-home supports as well. So we did see a bump down, if you will, in our in-home supports, but then we also saw that it was slightly increased because we put in a lot of protocols in place during the pandemic, and families felt safe with what we were doing. We were very transparent. We were very upfront with what we were doing. If it was a risk for us and a risk for the family, we wouldn't do it. And we were doing as much as we could for in-home support hours because we knew that families needed that respite. As much as virtual services provided, we needed to give opportunities for folks to get out and do things in the community in safe environments. And that's what we did with our in-home supports, is to provide those opportunities and respite. So those are the things that we did. One of the things I think that was very helpful during this process was I chair our local ARC group here for the state of Connecticut. We met every single day via Zoom. We met every single day with all of our ARC providers to talk about what ideas were working, what trends we were seeing, how could we come up with policies, procedures, what could we do better to ensure the health and safety of our people served and our staff. And that network of ARCs is huge and has been huge the last year and a half during this pandemic. More than ever, we saw the value in being an ARC chapter and an ARC provider. And I know this is a shameless plug, but it really did make a difference. And I think we did save a lot more lives because of our efforts collectively. Next slide.
All right. And now we turn to the panel discussion. We have a couple of taking a look at the data over the course of the last year and a half, as we now pivot to talk about booster shots, how we educate on the vaccination, vaccine access, and some of the silver lining and employment opportunities. The data that we've been looking at over the last year and a half help us. First, we have a question from Peter in Louisiana. Is there a good way to find more local data? I'm in Louisiana, for example, and I have a hard time trying to find reliable COVID-19 vaccine and IDD data.
I'll take a stab at that, because when we started last December, looking at what the stated priorities of the state were for who was going to get vaccinated first, we immediately saw that IDD was low on the list. Soon after that, the data backed up moving certain populations, but it was exclusive to certain segments of the IDD community and not the entire IDD community. And so for our effort to make a difference, we started with, I mean, we certainly had our own internal data, but the stated effort from the Department of Health and Human Services was, we're going to follow the science. And so immediately we went out we went to several places. We went to the CDC and started pulling all the data on adverse effect of any illness, and then on people with IDD, and started dialing that back into what do we know currently about COVID. And again, that data set has grown over time. We also went to Johns Hopkins University, who once we got past our finish line of getting people vaccinated, I didn't spend a whole lot of time going back and looking at it, but they were publishing at the time, and they may still be, where every state is in terms of IDD and who is in what category, and a lot of time spent on that because every state measures it differently. Everyone has their own plan and everyone has their own approach. And so when somebody says you're in group 1A and you're in the primary group, and they had different names and different identifiers for every different state. And so we tried to create as much as possible an apples to apples conversion. So we were going out weekly and looking at the new information from Johns Hopkins and saying, okay, what does that mean to us? And then turning around and forwarding that data back to our state department saying, listen, we're like everybody. North Carolina likes to be competitive with other states, particularly in the South, and that's always an issue. And so we said, hey, listen, look at these states in the South. Tennessee is vaccinating their people. How come you're not going to vaccinate us? And we played that role. And certainly, the data became a major issue, but the anecdotal information and the fact that we had major partnerships. This was not just an ARC only, us only doing the effort. There were several partners that collectively we were meeting weekly to go over what's the latest strategy, what do we need to do. But certainly there is data available, if not specific to Louisiana, then definitely to, the statewide effort is probably easy to come by, but then to be able to push it out and say, what are the other states in the South doing? And that information certainly is available.
One of the things that we did in Connecticut is the governor put together a vaccine rollout committee, and it was medical professionals and also a lot of stakeholder groups in the state of Connecticut. And we actually connected the ARC group in Connecticut. I mentioned our CCE group connected with one of the co-chairs of the committee. He is a doctor at Trinity Health Center. He's actually the president and CEO, but he's also a medical doctor there. And we connected with him and advocated with him about our population. And he brought that information back to the subcommittee. And that was, I think, a great opportunity for us to have a seat at the table to understand that this population was advocating. He actually emailed us and thanked us for advocacy efforts, because that enabled him to push that needle even further, no pun intended, in terms of getting people vaccinated. So that was a big help, but I would recommend that you go through your Department of Public Health. I'm sure that your Department of Developmental Services has information collected, or they are in the process of collecting that, but that's how we found in Connecticut that we were able to move that process forward.
All right. So I think we're familiar, I think for all of us, seeing the changes come through week by week, sometimes day by day, have been a lot more rapid than most of us are used to in our careers, especially over the last year and a half with the guidance that's come through. When we first put together this conference session, it was earlier this year. So the headlines were all about access to vaccines. And this was supposed to be a conversation about access to the vaccines and who could get them when. As we fast forwarded to August, really putting the final touches on this, we realized that some of those pieces are helpful, but at this point, anybody that wants one can generally get one. And the focus changes to booster shots, which is interesting, putting together presentations and putting together policy during this public health emergency because of how frequently things change, right? Even this past week, we got some guidance for people 65 and older, and with comorbidities for booster shots. CDC had some, the panelists had some data, and some of that was overruled. It's interesting where we see this going, but we do know that booster shots are coming up. I think it made headlines today that even President Biden is scheduling his own booster shot today. He's over 65. And so that becomes our priority. And a lot of these lessons learned of how we were able to reach between 75 and 98% of the population, those people that we weren't able to educate and to reach in the first place. You know, and also all of those that we did, and it's time to do it again. This becomes a focus, and why the data here is so important to help us recognize how we do this in whatever this next round is. Do we have questions for the panel?
I will say that as we shift gears from getting ourselves high on the list of priorities to be vaccinated, which was, again, it was a monumental effort this last winter, to now going back and saying, okay, we have people within our population that have chosen not to. In a person-centered environment, it is all about not just saying, do you want to get vaccinated, but helping people understand what the implications of choosing to or not to get vaccinated are, and supporting them in that decision. And to me, it is a very similar approach, just applied differently, to reaching out to the Department of Health and Human Services and saying, okay, guys, you're saying it's all about the science. We're sharing the science with you. We need to turn that around now with this latest effort that we have to have, which is the same. It's an effort to educate and to help people understand what choosing to get vaccinated or not choosing to get vaccinated does, and particularly with staff, where it's become a very complex matter for a lot of places and a lot of organizations to recognize that, you know, for me as an exec to deal with the people that have just said, I'm not going to get vaccinated, fire me if you want, or the people that are getting vaccinated and saying, shame on you for not getting vaccinated. Those are easy people to work with because we know who they are and we know kind of where they stand, and it's a different approach to each. It's the folks in the middle that are still waiting to make a decision. Well, I just haven't gotten around to it. Helping them make that decision, and then going back to the people that we provide those supports for and the people that we serve. How do we help them understand the implications in appropriate fashion to their needs and their capacity, and then to be able to really step out and say, you know, make a decision. But the longer you wait, you know, choosing not to decide is still a choice. If you want to quote Rush song, you know, if those of you that are familiar with the rock band, if you choose not to decide, you still have made a choice. And that's really where we want to be, is making sure that people are able to make a choice by decision, not by default.
We're in the process of setting up a booster clinic for our individuals and our residential services. That we found very successful last winter, as John had mentioned, and it was a quick, easy way for our folks to get vaccinated. A lot of our folks have some hesitancy towards needles, or people in doctor coats or stethoscopes around their necks. You know, some people don't like hospital settings or going to the doctor. So we needed to find ways to get them vaccinated in a very friendly environment that they would be comfortable in. So that's one of the things that we did is we held the clinic here at our organization. So it was a way of breaking down that barrier. And we're planning to do the same thing this coming October with a booster shot clinic, once again, to get those folks that extra shot to ensure that they are immune to this virus. So I would encourage you, if you haven't done a clinic or haven't partnered with one of your local pharmacies, to do so, because it's a lot easier for everyone involved. Not only staffing schedules, but also just the schedules of our people served. It just makes life a lot easier when you can control some of those variables. So if you haven't done that, do so. I know in Connecticut, we did several agencies, several ARCs did clinics, and then we also hosted some statewide clinics for the Department of Developmental Services. And we partnered with them along with the hospitals to provide that opportunity, because we knew that you know, we can make people feel comfortable in our environments, and it's a better outcome when you can get 20 or 30 people their shots instead of 1 or 2 people walking into a local CVS or a Walgreens or wherever they're going, and taking time to do that. So just a thought process on that. You might want to reach out to your folks within your Department of Public Health and see if you can host a clinic.
When we talk about education and advocacy and communicating with people, one of the really interesting items that came up is how do we help educate people that are still on the fence. There's still right about a quarter of the people that we supported in this study still have not gotten their initial vaccine. So while 75% or 78% we were effective with, there were a cohort that we were not. And one of the things that came up as we together were looking at the data and helping to identify it was something pretty interesting and pretty helpful. So I'm going to go back. We have this slide here. One of the things that we found, we expected, well, it's, the hypothesis was this would look different in rural counties than it did in urban counties. That's not true, right? The hypothesis was this would look different, based on political lines. That's not really true either. John had a great quote as we were looking through this, that sometimes, John, what was the quote?
I'm trying to remember which one. I float several of them.
Sometimes the not having a clear trend is a clear trend.
Yeah, well, yeah. Sometimes when data doesn't tell you anything, it's telling us something. It always tells a story, even if it's not the right data.
And that was particularly helpful. And I think the realization, the light bulb that turned on for us, especially related to education about vaccination, was something that we've all been understanding, adopting, preaching, and living for decades, which is a person-centered approach. There is no one-size-fits-all approach to encouraging everybody to get vaccinated. The person-centered approach means talk to every single person individually, find out what their concerns are, work with each person. Isn't that what the entire person-centered approach is? And guess what? It applies to vaccinations as well. And that was one of the kind of breakthroughs that we came through here is especially for the 20 to 25% of people that have not been vaccinated yet. It's an individual conversation with each person. And that's kind of what we've all been trained to do and our ethos in the first place. And here it is again, so that we found that to be helpful. We also took a look at vaccine access. We've spoken about that. We did have another question from John at the Arc of Oregon about, we may not be able to answer it here, but for the people, we've all been living through an interesting labor market, I think, as all the chapters of the Arc are very familiar. And for the people that we support, are there numbers available yet for those people that are maybe working remotely, kind of like we are right now, beyond state lines, possibly working at lower minimum wages, so that their benefits are not impacted? Do we have any data or stories yet? And I said that we would certainly start to look, but as more and more people can work virtually, and people with disabilities are always, especially people on Medicaid waivers, do have their benefits and have to take a look at income. Do we find that people are working jobs virtually at potentially lower wages in order to to not affect federal benefits? John or Kevin, have you seen that yet?
I haven't seen it.
Neither have I.
But we are going to take a look. I mean, we do have data on where people are working and some of that, and that definitely does become interesting over the course of the next year. Oh, John, your hand is up.
Main question is career-based jobs. People with disabilities now are going to college and all that type of stuff. We have 6-week pay months to 4-week pay months in a way that affects our benefits. I would personally, for those with disabilities, would like to see 24 hours, per week, but they have to always adjust to their employer what type of job. So you have to go to, my state has a very high minimum wage. And so federal benefits are very hard. So data that could support in a way of maybe working in another state, I can then also put in our ABLE plan to other resources, is what I was trying to refer to if there wasn't that type of resources. So I apologize for speaking up, but that's where I was wondering where the data was on your employment services, because employment coaches, employment specialists are not new, but it's a new field. And they can't really sometimes understand, it's hard to communicate, let's just say, to that on a national or local local, company. So if there's data on other people with disabilities that have to work in say Texas for lower rates so that we can work more hours so we can become full-time employees, not off the system, but, so full-time employees later on in life so we can have a retirement benefit. That's what I was trying to communicate on that. So I appreciate you guys taking the question and sponsors of the ARC of US for letting me ask that question on this platform.
Certainly, thank you. You're right, the state-by-state differences, no question about it. We see it all the time, and we can definitely take a look into some of the data and hopefully at next year's conference start.
Absolutely. And last point, if there's a way that we can even communicate to universities or trainer-to-trainer modules or other places, that also will help in a way at least giving us a start so we can help you and help the ARC of US or wherever we are. I'm not trying to make it a platform, but for the employment services, it's just something I wanted to ask. Thank you very much for taking that question.
You're right. Thanks for the question. In the last few minutes, we also want to try to pull everything together from what we talked about today. So I think everyone on this call probably knows that individuals with IDD supported by providers are more likely to have comorbidities and severe outcomes from COVID-19. In our samples from Connecticut and North Carolina, between 75 and 98% of individuals with IDD were vaccinated for COVID-19 initially. Looking at the data, we identified cohorts of individuals that were not vaccinated. This is important as we move into booster shots. We also analyzed changes to services before and during the COVID-19 pandemic in hopes of understanding the future of service delivery. So that kind of took us through a little bit of our tour from today. We've got a few more minutes for questions, but we wanted to thank everybody for coming to our session today. See, it didn't hurt at all.
And thank you, Doug, John, and Kevin. I do want to remind participants you can type your questions into the Q&A function, which can be found at the bottom of your screen next to the chat button. If you prefer to ask your question aloud, use the raise hand function. That will prompt the host to give you permission to unmute your mic so you can ask a question. With that being said, I'll turn it back over to our speakers to start answering questions or final remarks or whatever.
I just appreciate the opportunity to be here and share some thoughts with everyone. Thank you.
Yes, and thank you for all that you guys are doing and we as chapters are doing to keep our people served safe, their families safe, and everyone safe. This has been a crazy ride, a crazy roller coaster, if you will. Every day the information changes minute by minute, second by second. At one point we were thinking. But I think collectively we have some of the answers if you join together with your local chapters in your state. I can't stress, I know that I'm going back on the soapbox here, but I can't stress how important I think it was for, I know us as Connecticut chapters to meet on a daily basis via Zoom, even if it was just to check in with each other. We shared policies, we shared documents, we shared just things that we're thinking of. We were actually advising other states on how to do virtual services. It was a great collaborative effort, and to this day we still meet on a weekly basis as we get through this pandemic. But it's important, and I think that just really stresses why we're part of the ARC and why we do what we do every day. It's important that, we come together and stronger, we have all the answers. I really do believe that. And people are very thankful that we did that. And as Doug mentioned, we did have one fatality through COVID, unfortunately, but collectively, we were able to support all the other individuals and minimize the impact of this deadly virus on our population. And I think that's really what it comes down to at the end of the day, is this information sharing is critical to the health and well-being of all of us as ARCs throughout the country. So I open that discussion, welcome that discussion, and I may not have all the answers, but I know collectively we have the answers, and thank you for all that you're doing.
We have a question from Patty. I hear a challenge on policy in disclosing vaccine status for individuals who want to volunteer for nonprofits, asking for volunteers to be vaccinated. Any standard policy or per agency?
We haven't gotten there yet. To be honest with you, with the Delta variant rising back up, we've decided not to allow visitors within our services at this point. It's something we're evaluating on a monthly basis. But for right now, we're trying to keep as much of this under control. And the way they control the spread is to control who has access to how we're interacting with our community. So as much of our folks go out in the community, they go grocery shopping, they go to their jobs, they do things. We definitely want to make sure that we understand who's coming in contact with each other. So at this point, we haven't even looked at our visitor, our volunteer policy of folks coming in. We've just sort of put that on hold at this point. I don't know what, John, you're doing in that. And
we have a little different role, and our local chapters do a lot of volunteer work. We do have volunteers connected to the ARC of North Carolina in some different capacities, certainly our board of directors and a number of committees and activities. But I would equate it to the same circumstance we have even with our employees. And that is, before we allow anybody to volunteer, including our board of directors, we do a very thorough background check. Of staff, of employees, of volunteers, anybody that's connected in that fashion. Based on that background check, we have far more information about you. We have your social security number, we have your bank account information, we have your driver's license, address, your ages. I mean, we have everything that we would need. If we really were intent on violating somebody's privacy, we'd have a much better way of doing it with that data and that information that we've already collected. The vaccination thing, we're certainly very respectful of somebody that wishes not to share, and we're careful with that. But given what we do, our first priority is the individuals we serve. If we turn that upside down and say our first priority is our staff, as much as our staff are right up there and very highly considered, but the first priority is that individual with a disability. Next to that, then we'll work with everyone else. But again, privacy issues, this is HIPAA. This is what we deal with on a daily basis. We are not going to expose somebody, volunteer or staff member, unnecessarily unless there is really good reason for it. And in my experience, we've never come across that reason. So just kind of a comparison of what the circumstances are based on, testing status versus the rest of your life and information. That is, to me, that would be a far more critical issue to protect than just your vaccination status.
Patty had a follow-up question for participants who are volunteering in the community. The disclosing their vaccine status, what are some policies looking like, or some guidance looking like for that disclosure?
So we're following any of the volunteer sites information. So if a volunteer site requires that information, then obviously we get it cleared through the parent or guardian. Or if they are their own guardian, then they can clear it themselves. But we're following whatever each employer, volunteer, any site that they may go to or location, their requirements are. So that's what we're doing.
And Patty mentions there are individuals that she supports with IDD ready to volunteer in the community, but the agency won't disclose if they have a vaccine, which is limiting people from getting back into the community because agency policy doesn't disclose that.
Well, once again, I think if any parent and guardian wanted to disclose that information, that's well within their rights as the parent or guardian, or themselves as a guardian.
In our circumstance, when we first got word that we were going to be getting vaccinations, and this was way back last fall, almost a year ago, we began looking very carefully on how do we deal with this, particularly in our guardianship program. Because I got word that one of our guardianship specialists, I mean, as a corporate guardian, the guardian officially is the board of directors. And as the exec, my role is to focus and to take care of all the issues that the board assigns to me. And this is one of those assignments. And then we assign the guardianship responsibilities out to our specialists across the state. And I heard that one individual was saying, well, they're not going to use my individual as the guinea pig. And that was disturbing to me as the executive director, because that is not a choice that person is allowed to make. Right or wrong, good or bad, the choice really belongs to the guardian, which is the board of directors, and there are questions of liability that we were looking at. Our board has established a committee, our guardianship committee, and in those committees we have local review groups that are volunteers from outside the community, doctors, lawyers, different people with experience that can advise us. And typically when we run into difficult things like a DNR, for instance, this is the review group that helps us make those decisions, and it really falls back on their shoulders. And so we said, before we have an individual guardianship specialist make that determination, we ought to be looking at what are the criteria we're using for making that decision. First and foremost of which, what is the individual's preference, and have we helped them understand that choice that they're making? If they're not able to make that choice, or maybe they don't want to get vaccinated, but they live in a group home or a facility where everybody shall be vaccinated. So there are extenuating circumstances, and we spend a lot of time crafting a policy that says, these are the things that you shall review. If it becomes an issue, let's walk down these steps. Let's make sure that the outside review committee is looking at this. And again, first and foremost amongst those issues is, what does the person themselves want? And are there extenuating circumstances that we would now have to take into consideration? Fortunately, we didn't have to run across that very much. But again, these are not, if these were simple issues, we wouldn't even be having the conversation, but they're not. They are very complicated, very personal things. And again, in a person-centered environment, how do we respect and honor the individual in a way that they are able to make this as much of that decision as they are capable of making with the kind of information that's available.
So with that, we have about 1 minute left. Hopefully the presentation will be recorded from today. Each chapter of the ARC can look at some similar data based on the vaccinations, the people that are supported, their comorbidities, their ages, how services have changed, and use that data to help with advocacy and education, much as we've done here today. And so with that, we thank you all for your time, and enjoy convention, everyone. Hopefully we see you in person next year, and thank you for coming to our session.
Thank you.
Thank you.
Thank you to our presenters, and thank you to the participants for attending this session.